Hey students, welcome to the Chapter 16 Voiceover lecture. This is the content on gastrointestinal disorders from your textbook, and I will be kind of guiding you through the PowerPoint slides and incorporating the notes that I would generally teach for this content in person, since you will not be able to see me in person this particular semester. All right, so let's get started. As you know, the first few slides are going to address the objectives that we have for students within this particular chapter. And obviously our focus today is covering gastrointestinal conditions that are specific to pediatrics or that are very common in peds and may also be the case in adult health, but we want to talk about what makes it different in the pediatric patient from what you probably have had or will have in the adult patient. Okay, so as we have started out pretty much every lecture, I want to remind you to just go and review the GI system in general, recognizing what you've already learned, definitely in patho and likely in med-surg. In this particular example, the primary thing is recognizing that the GI system is a very comprehensive system. It's every organ in the body from the mouth to the anus, and that is basically, dictating every organ within that distance that has any kind of role in digestion or the elimination process. So this includes the esophagus, the stomach, your small intestine, your large intestine, your liver, your gallbladder, your bile ducts, and the pancreas. So all of that is encompassed in what we consider the GI system. So you'll see us talk about the different elements of medical conditions and which organs specifically they're affected whenever we're talking about these specific diseases or conditions. So some questions that are important to ask whenever we're assessing a pediatric patient and we're trying to determine if there's any concerns related to the GI system would include things like, has the child experienced any recent weight loss? We don't expect weight loss in pediatrics. The growing trend, and this would be the case through all of the pediatric lifespan, is that they're continuously gaining weight, or if nothing else, maintaining weight. And so we want to find out if there's any situations in which the child's losing weight. Have they had any recent travel, specifically outside the country or to places that may have poor living conditions that might cause some kind of infection to the GI system? When the patient's experiencing discomfort or pain, does eating help it or make it worse? Does being able to eliminate the body, like passing stool or even urine, improve the symptoms or worsen the symptoms? And also knowing if there's anything significant in the family or social history that might pertain to the GI system. In pediatrics, we've talked about already how crucial it is to complete a full assessment when that's necessary, but recognizing that sometimes the sequence of the assessment has to be adjusted based on the child's cooperation level and how they're presenting. And in many cases in the body, that's fine. Like if you're choosing to palpate and then later auscultate, it's not necessarily an issue. But in the GI system, it's very important that we pay attention to sequence. And so the primary takeaway in the GI system is that auscultation, listening to the bowels, should always come before palpation or touching of the bowels, because we understand that palpation of the bowels through our touching on the abdomen in different locations can change the quality of the bowel sounds and interfere with the accuracy of the assessment we're trying to obtain. So with that abdominal exam, we're going to start with inspection, where we're basically just visualizing the abdomen, and that's looking for things that we would expect to be different from the ordinary for a child in general or for this child specifically. Like, do they have a protruding abdomen? Do they have noticeable abdominal distension? Is there been any change in the size or shape of their belly? Then we're listening, and that's allowing us to dictate if there are active sounds present in all the quadrants. And one thing that differs a little in the baby, the toddler, even maybe the preschool age child, is that many times you'll see the nurse do an assessment that's more bilateral. They're going to be listening on the left and the right bowels, but not necessarily upper and lower too, because when they're using their stethoscope to listen, it's basically encompassing both the upper and lower. And so that's not a situation where the nurse is taking a shortcut or not doing a thorough job. It's just not needed because of the baby's size or the toddler or preschooler size. Whereas as the child grows and they become older, then you're going to see the adult assessment technique mimicked, where we're doing all 4 quadrants of the belly. It's definitely going to be easier to listen to the baby's or person's abdomen when they're quiet. And so an opportunity like when we would be listening to their heart rate and their respiratory rate while mom's holding them and they're, content, good idea to go ahead and just switch on over to the bowels from there and complete that auscultation portion of your assessment as well. Percussion is obviously when we use touch in different ways to try to understand if there's any change in the dullness or volume of the belly. And so what we know to be true is anytime you hear tympany, that's indicative of gas, where dullness is indicative of fluid. But percussion is typically reserved for your advanced practice registered nurses and providers. So I don't know how much we get into it in the curriculum in the other courses, like in your adult health courses, but that would pertain to this as well. And the primary thing being the fact that you listen before you would begin that percussion attempt. And then also that you're listening before you begin your palpation. And palpation does involve using the whole hand, or in this case, to reference specifically the entire palm, because when you're doing the palpation, you're laying your hand on the baby's belly and you're kind of making wave-like motions, and that's allowing you to gently flex your hand and determine if you're finding any places in the abdomen that are hard or there's masses versus what we would expect, which is soft and flat. It also can help you to identify tenderness in the child. So if they're, reacting or they're guarding whenever you palpate, that's a good indication that there's some kind of discomfort in that area. Okay, so kind of moving into what are some important elements of the GI assessment. And another element for that is looking for indications in your assessment that speak to hydration status for the patient. So we need to know what are our dehydration indicators and how do we evaluate them? Like, what is our assessment technique for those things? So, one thing we know to be true is when dehydration exists, a lot of times there's some alteration in mental status. So there can be some confusion, some lethargy, increased fatigue. That's going to be harder to distinguish on, say, a baby or a toddler than it is on an older child or, obviously adolescent, who can tell you, like, I don't feel right, I'm out of energy, I'm speaking in a way that indicates confusion. We know that tinting of the skin would be an indication of dehydration. So that's whenever we're assessing skin turgor, which in your adult patients, that typically is done on the back side of the hand. But for our pediatric patients, we typically assess that in a different location, and that's usually midline on the anterior or trunk of the patient, and it can be sternum kind of high in the chest, or it can even be, midline on the abdomen. But that's generally the places that we're checking for skin turgor in a pediatric patient. Their fontanelles. Now that's going to be specifically our infants to early toddlers, because remember we talked about the anterior fontanelle, which is the one located on top of the head, usually has closed by 18 months to 2 years, and we would definitely expect that closure by 2 years. But when they're younger than that, then that's a great place to be checking for this possible indication of their hydration. What you expect in a normal assessment of fontanelles is that it be flat. So when I put, my hand on it, I feel it. I mean, there's like a little dip to it, but, it doesn't droop down, just like it doesn't bulge out, okay? When we're talking about depressed fontanelles, that would be like a sunken fontanelle. So that would be like, you being able to like basically run your fingers down into that, and usually that's a noticeable distinction. Their membranes, mucous membranes, so the mouth, the nose, we would expect those to be moist, but if there's dehydration, then they typically will be dry. And so we can evaluate that for them. We can also look for tearing, like when they cry, are they having tear production? Now, you might remember from our content back in chapter 8 that it's typical of newborns and early infants not to have tears, that's just part of their normal system at that age. And so obviously we have to consider the child's age as to whether we would expect that tear production or not. And then obviously urine output is a great way to evaluate hydration status. And so for our pediatric patients, depending on if they're potty trained or if they're still in diapers, is going to give us some indication. We need to know if they're in diapers, how many times a day do they have a wet diaper? And we need to know what is the norm for that, which that's going back to chapter 8 content as well, where we expect a baby to have between 8 and 10 wet diapers a day. If it's significantly less than that, then there's a good chance there's dehydration to be considered. And then obviously once they're toilet trained, then it becomes how frequent are they going to the bathroom, and do they just have a little bit of urination when they go, or what we would consider a sufficient volume. When we do identify dehydration in a patient, we have to know how to treat it. And so in discussing that, we're going to look at a few different things. Oral rehydration is one approach, and that's when, we feel like the patient can consume or, handle oral intake. But this specific portion of the slide is speaking to IV therapy or IV resuscitation of fluid. And so knowing what are the appropriate solutions for that, and that would be both your normal saline and your LR or lactated ringers, because those are isotonic, and then knowing what is the recommendation for the volume for your patient, and that's weight dependent. So we're talking about knowing their kilos for their weight, and knowing that for a bolus, we would expect them to have an order to need 20 mils per kilo, and that would be administered in a 20 to 30 minute time frame. When we talk about maintenance fluids, so that's different from your bolus. Bolus means I'm giving a larger amount in a shorter amount of time. Maintenance is I'm going to give a larger amount in smaller increments over a longer period of time. So with that, the formula changes to 10 mils per kilo of weight. And then it also includes their ability to orally rehydrate if they can tolerate it. These are important formulas to know. This is a great way to incorporate a drug calc on this particular content. When we get to this unit, on the exam, this would be a great thing for the instructor to ask is, based on this patient's weight, what do you expect the order to be for bolus IV therapy? Based on this weight, what do you expect the maintenance fluids to be for this patient for IV therapy? So I would definitely commit this to memory. Okay, so what we're going to be looking at now is we're starting our specific conditions within the GI system, and this one's going to be the section on conditions associated with abdominal pain. Now, please don't misunderstand this. It doesn't mean that nothing else to come will also have, abdominal pain or discomfort as a manifestation of it, but this is kind of just how this one primarily presents, and it didn't fit into the other categories that the PowerPoint has been divided into. So the first one we're talking about is celiac disease, and this should be, I hope, something you've heard of before in the nursing program. This is an immune response or an autoimmune disorder that is generally genetic or hereditary in nature, in which the body has an intolerance to gluten. Be careful with what you interpret that to mean, because it's not actually an allergy to gluten, it's an intolerance to gluten. So basically what happens is when the person who has celiac disease consumes gluten, the body then attacks itself, specifically the small intestine, and it's causing damage to the villi, and that is creating this interference with the ability to absorb nutrients. So make sure that you, if needed, find different definitions till you find something that you can clearly understand, that helps you to understand what's going on in the body in this particular condition. Gluten is something that is very common in our nutrition routine. It's found in wheat, rye, barley. And so basically, typically whenever a patient experiences this, we start to see indicators of that when they begin introduction of foods that have these properties to them, these food sources. So that could be as young as, infancy. Like that can be our, 4 to 6 months old when we're starting to introduce solids. We're incorporating something above and beyond formula and breast milk. Now, just because that's when it could happen doesn't mean it will. And some people don't discover their intolerance to gluten or their actual diagnosis of celiac disease until much later in life. So it's not something that is a given in early childhood. It can be something that's discovered later on. So what do we want to do in this situation? Or actually, let's start with what can we expect the patient to experience symptom-wise? And that would be a combination of the manifestations listed: bloating and gas. They typically have some combination of nausea, vomiting, and diarrhea. When they have bowel movements, that stool has a very strong and foul odor, more so than what we would all anticipate with stool. The patient tends to have weight loss, even though they're eating in what would seem like an adequate volume. Because of the interference with nutrient absorption, they're actually not going to put on weight the way that you would expect. And with that weight loss, or with that inability to gain appropriately, they tend to have deficiencies in some of the core vitamins and minerals in the body. Some examples including iron, B12, and calcium. And it can even translate to having some delayed growth and development, especially the younger the person. Now, obviously, when we see this diagnosed or really discovered in later childhood, most of the time they've already met the milestones, but it actually might be that there was some delay and it just never was known what the explanation was prior to this. So how do we manage it? Basically, we're looking for that patient to be on a strict gluten-free diet. We have to recognize that if the body is intolerant to gluten, if what's happening anytime it's consumed is this attack being mounted on our own body, on our small intestine, then any exposure is going to have that potential consequence. But as much as can be eliminated from the diet, the symptoms can be managed, as well as, the complications that can arise from it. Okay, next condition, and I have a little note for me to say it here, is appendicitis. And this is one that y'all are going to be covering more in depth in MedSearch 2. So I do want to speak to it, now in pediatrics, because it may not be something you've had a lot of class or didactic content on yet, though I know most people are pretty familiar with appendicitis. And again, it's not one that is just reserved for pediatrics. It can definitely occur in adolescence and adulthood, but it is very common in children, and so we want to discuss it here. So appendicitis is when there's inflammation of the appendix, or the pouch connected to the colon, that's located in the lower right quadrant of the abdomen. This particular, structure becomes inflamed and generally infected, and creates this very continuous pain for the person. This lower right quadrant pain can be evaluated using what they call McBurney's point, okay? And what they typically see with this is that there's what they call rebound tenderness. So when you're palpating in the right side, let's see, let me say this correctly. When the left side is palpated and released, the tenderness occurs in the right side. So the right quadrant is where the pain is most pronounced. So we're going to feel it there, but we're going to really feel that intensifying pain when we go to evaluate the opposite side, the left. When we palpate and release, it's causing this rebound tenderness to occur. Other manifestations for the patient would include nausea, vomiting, and diarrhea. It may not be all three. It may be any combination of those, as well as fever. Many times with appendicitis, a fever spikes and it doesn't easily resolve even with your medication administration of antipyretics. The patient will likely have to lay in a position that's creating as much comfort as possible for them, which involves their knees being bent and kind of tucked into their stomach. So with this particular problem, there's really only one treatment for it, and that's surgery to remove the appendix. Unfortunately, in some instances, the surgery is not performed fast enough. Maybe the diagnosis is not made quickly enough, and what they end up experiencing is this sudden relief of pain. And you would think, oh, that's great for the patient, but it's actually not, because anytime that pain that has been constant is just suddenly resolved is actually an indication that the appendix has now perforated. And that's dangerous, because with perforation, now we've allowed all of that infection that was culminated in that one location is now going to be spread throughout the abdominal cavity. And so with a patient who has a perforated appendix, though they may feel a little relief in the amount of pain they're discovering, they're actually going to end up with a longer hospital stay, because now they're going to require IV antibiotics and more close monitoring, NG tube in this case, to help suction and remove any of that infection in their abdominal cavity. It's actually going to make for a longer recovery for these patients. So you'll see that, in addition to surgery being required, incentive spirometer, that is to help the patient to still take adequate breaths. We want them to still be breathing appropriately. And what tends to happen anytime there's some kind of surgical incision is that, the patient's going to reduce their breathing or not, do so as deep or as frequent, because they're trying to protect themselves. They're trying to minimize the discomfort. And so incentive spirometry is going to help with keeping the patient from ending up with some other kind of infection like pneumonia, for example. So the NG tube, that would only be applicable in this scenario of a perforated appendix. It would be kept on like low, intermittent to continuous suction, where it's helping to remove any, remains of infection in the abdomen. Non-pharmacological methods. So, obviously we would expect medications to be administered for this, and that would be, pain reducers specifically, but there's also non-pharmacological methods that can be used, like massage and distraction and music, which, are not limited to just appendicitis. That would be something that, we try to incorporate anytime a child or a person is experiencing some kind of compromising health condition. Excuse me, we do expect them to have restrictions in their activity, because obviously they just had major surgery, and we want to make sure that that surgical incision stays intact and heals properly. But we don't want them to be, bedridden, no movement, because then we see again the dangers of a patient who's not having adequate breathing, not ambulating. They can end up with blood clots. They can end up with a lung infection. So we're still going to be encouraging them to have, some ambulation, deep breathing, just with some, restrictions to that. The patient needs to be encouraged to adhere to their medication regimen, whatever that looks like, any follow-up appointments, and then also obviously be knowledgeable of monitoring that incision site and being aware of what would be signs of infection that might need to be reported once that patient's been discharged. They would have limitations in their lifting abilities and obviously vigorous physical activity for several weeks to follow. And the medication regimen portion of this is important for an appendix that was removed before perforation in terms of pain management, but even more so for that of a patient who had a ruptured one because of the need to make sure that all of that infection is removed. And so those antibiotics, that compliance with the antibiotics that have been prescribed is very important. Okay, our next condition, still in terms of abdominal pain being the primary manifestation or the consistent manifestation, is an inguinal hernia. And a hernia in general should be a term you've heard of before. A hernia is when somebody has some kind of protrusion of tissue through an area it's not meant to protrude through. So, we'll teach in this content specifically inguinal, but there's also umbilical hernias, which means it happens in the umbilicus region. Very common, especially in our infants and toddlers, usually harmless, benign, if you will. It typically resolves on its own over time, and there's some ways in which we encourage, assessing that for any kind of complication. There's a diaphragmatic hernia, so a hernia that occurs in the diaphragm. That's very dangerous, one that requires intervention like surgery and definitely close monitoring because it's affecting the diaphragm, which is impacting the breathing. So obviously a lot of danger in that if it's not treated and managed appropriately. But in this one, we're talking about an inguinal hernia. We're talking about the inguinal region, so that groin area. And this is, very typical in our babies, our infants and young toddlers. So basically what happens is there's this protrusion of tissue through a defect or an opening in that inguinal area. It's intra-abdominal contents that's pushing through these inguinal rings, and it'll manifest as like a lump in the groin. Usually kind of in the similar location to, where we would see the scrotum on the patient. The scrotum is obviously beneath the penis. This is, actually in the groin area of the patient, and it would be its own lump. It can be bilateral. It can occur on both sides, but usually it presents unilaterally, and anyone that does have one, unilateral included, is at greater risk of having an additional one at a later time that would be either recurring on that same side or on the opposite side. I mentioned hydrocele on here because that is something else that I think we'll have talked about by this point in the semester, because it should have been in our chapter 19 content, and we kind of tacked that on with chapter 7 and also with chapter 11, adolescence. But hydrocele is something that can be confused or be mistaken for an inguinal hernia. But they are different things. It's similar in that it's this, lump or this growth almost, but different substances, because hydrocele is fluid and the inguinal hernia is intra-abdominal contents, it's tissues. So it does require surgery to have this removed. Let's see what other things I had in my notes. And the frequent diaper changes would be a post-op measure that we would be doing to try to keep that surgical incision clean. So, trying to make sure that as often as possible, we're preventing any exposure of feces and even urine to that site, which could cause irritation or infection. A concern is incarceration of the inguinal hernia. This would be something we'd be worried about before the surgery has happened, in which the patient would suddenly have magnified pain, a fever, changes in their vital signs like tachycardia, and they typically will experience vomiting that's bilious in nature, which is like bile, which means that's the consistency of the vomit that they're experiencing. And a lot of times it can even restrict the ability to eliminate stool, so they'll also become impacted, if you will. And that's obviously dangerous and requires immediate intervention, just as strangulation would. These terms, incarceration and strangulation, that's a possibility for any kind of hernia. And in strangulation, that situation is when that mass is actually reducing blood flow to the area, so the patient will experience redness or erythema and edema, swelling, on top of that tender mass that they have. Okay, we talked about the frequent diaper changes to keep that suture line clean, continuing to assess circulation on the side that had surgery, but also continuing to monitor the opposite side, since it is an increased likelihood that a baby or a child with one could develop another. And then I have in here, just in reference to umbilical hernias, that those are very common. They usually do not require surgery, and they do usually resolve on their own. That way that we mentioned, I was kind of alluding to how you evaluate it, is, you basically should be able to push down, or I would say retract, the umbilical hernia. This is again happening at the umbilicus, so at the belly button. You should be able to push it down and it basically sink back inside of the belly, and then when you let go, it should rebound or retract, and there should be no discomfort for the patient with that. I mean, it's just a, basically bouncy part of tissue that you can reduce and it will return. It shouldn't have any color changes to it. It shouldn't have any warmth or swelling to it, and there shouldn't be any pain associated with it. And typically over time, it will go on its own. If you've ever heard of or seen a baby with a quarter, like a coin, taped to their belly button, that is an old wives' tale, or myth, that is a way to help reduce umbilical hernias. Your textbooks will not advocate for that because it's also a source of infection. So, but if you've ever seen that either in a movie or you've heard, of a grandparent saying, "Oh, put a quarter on that," that is something that in the olden days was tried to help heal the umbilical hernia. Okay, continuing on. Inflammatory bowel disease, and specifically looking at peptic ulcer disease. I have noted that this is also one that will be covered heavily in MedSurg 2. I also made a note to point out that there is a portion in the textbook on page 370 that's labeled clinical judgment that differentiates the symptoms for the patient depending on their age. So if it's an infant, the symptoms or the manifestations you can anticipate seeing would include hematemesis, so basically bleeding with vomit, melena, distension, and distress, respiratory distress. With toddlers, it more often presents as anorexia, so that refusal to eat, as well as vomiting and bleeding, and it doesn't specify where that bleeding occurs, but I would likely expect it in the fluids the patient is eliminating, whether that be vomit, feces, possibly even urine. Preschoolers experience pain when they're waking up, and it does not feel any better with consuming food, so eating does not make it improved. School age and adolescents have basically the same symptoms or manifestations as the adult patient has. So what is peptic ulcer disease? Peptic ulcer disease is when there are ulcers or sores that are located along the stomach lining or small intestine. Where they are specifically is what helps to distinguish the type. So you can have gastric ulcers or you can have duodenal ulcers. Obviously, those that are gastric are in the gastric cavity or stomach, and then duodenal will be on the duodenum. Typically, it results as a consequence of either an H. pylori infection or long-term NSAID use. So a great example of an NSAID that abused or used too frequently that can cause this would be ibuprofen. So a patient who, has Motrin or Advil for an extended length of time. As previously said, the manifestations can vary from person to person, also from, different age groups, and can even be asymptomatic early on or initially. But what typically is going to develop is they're going to experience abdominal pain. They're going to have what they describe as like a cramping pain, and they're typically also going to exhibit nausea and vomiting. Changes in their eating pattern where they're maybe not wanting to eat. This kind of pain can actually keep them awake at night or make them wake up during the night. And severe enough, it can result in bleeds in the GI tract, perforation, even, and ultimately a complication would be shock. So how is it managed? Well, in its initial stages, the gut needs rest. We need to allow for those ulcers to heal. So ways in which that can be achieved is making the patient NPO and giving them, alternative nutrition in the form of what we call triple therapy, and then avoiding, whatever is possibly the original irritation or cause. Like if it's from long-term NSAID use, then obviously they need to not be on NSAIDs for some time. Okay, irritable bowel syndrome, IBS. Will be covered in MedSurg too, but this is very common in children. It's considered a chronic condition. This particular condition is associated with the large intestine, or what we call the colon, and we see it in all populations, but it's even more prevalent in females, especially in those who are experiencing puberty and when they have started having menstrual cycles. So, it tends to escalate in that period of life. The patient exhibits cramping and abdominal pain, bloating and gas, and alterations in their elimination that could be diarrhea or constipation. And it's usually triggered by certain things, like certain foods that they're eating are creating these symptoms. So what we want to ultimately do is try to identify those triggers so that they can be avoided. And so one way might be like a food diary or food log where, in this case, if it's an older child, it could be the patient themselves, but it may have to be the parent keeping track of what they're eating and when the symptoms are the most prevalent or the most, painful, because it's probably associated with something that they're experiencing in their nutrition. Other, recommendations for this patient would be small meals instead of large meals, and meals that include increased fiber content and fluids, because that's going to make it easier for them to eliminate what they're eating. And if they were experiencing constipation, then that increased fiber and fluids is going to help to counteract that constipation. These patients may also need meds, many of which can be purchased over the counter, though obviously with pediatrics, you always want to identify with the pediatrician what's safe to give and, what frequency and what amount. But some examples of meds would be laxatives, Imodium, being on probiotics, because that helps to balance the natural flora in the intestine. Even fish oil supplements and fiber would be other examples as well. Now we're talking, and let me just kind of a timeout to the slides for a second. We're talking a lot about how these conditions manifest and what is the management of them. And that I know probably seems more appropriate for a provider, like somebody who's going to be diagnosing the conditions and then treating the conditions. So where does the nursing role come into play? You have to be able to know this information enough to then determine what's appropriate management and care as the nurse with this patient. So even though you're not going to be the one making the diagnostic, for the patient and writing the prescription for whatever treatment measures are needed, by understanding these conditions and how they present and how they're managed is going to allow you to answer exam questions, but also provide care for the patient that's appropriate for them. So your role might be helping the family come up with a food diary that, eliminates some of these triggers or helps to figure out what are the triggers and then help find alternative foods to satisfy but not have the same impact. It might be the recommendation of eating more frequently throughout the day but smaller portions and making sure that it's supplemented with these higher fiber foods and fluids. Recognizing if what they're experiencing is something that's acute in nature versus something that's chronic in nature, because obviously they're going to be managed differently depending on the nature of their condition. So it is still very important for the nurse to understand it, though I know it seems like I'm leaving out the nurse's role in this. In a lot of instances, the nurse's role is going to be pretty consistent throughout the GI system, depending on what the patient's presentation is and what's the appropriate treatment for whatever they're experiencing. And I hope that's going to make a little bit more sense as we get through the rest of this PowerPoint. Okay, so now we've kind of segued. We've been talking about all these conditions that are primarily associated with pain. Now we're going to talk about a few that are really marked by vomiting. And so this first one should be familiar to you. We've talked about this in our Chapter 8 content when we talked about newborn and infants, and that's reflux, or the full name of that would be gastroesophageal reflux disease, or GERD. Now there is a distinction in a medical diagnostic resource that differentiates reflux from reflux disease. So GER, G-E-R, from GERD, G-E-R-D. But for the book purposes and for our test purposes, we're learning GERD, okay? And really, the best way I can easily speak to that differentiation is that this is the continuous symptoms in the patient. It's not just a brief time in which they're experiencing these episodes, and it's past the point in which the patient should be able to, if you will, have outgrown it. Okay, because to some degree reflux is just normal, like we expect it earlier on in life or in infancy, because all of the structures of the body are still immature and they're still strengthening, so that immature esophagus is going to have this easier gag reflex. It's a more floppy structure, and so this tends to occur. But what we would expect is that as those structures mature, this would be something that they would outgrow, and when they don't, it's given the diagnosis of disease, or the label of this condition. So as said, it's due to immature esophageal sphincter causing the gastric contents to backflow. So a great way to visualize this is say you're eating something. Let's go with, for me it'll happen a lot with rice or something that tends to expand when it's wet, okay? So you're eating that, and it's supposed to be traveling down. Once it goes down your throat, you don't expect to see it again, right? Until it, comes out in your elimination patterns. But when this sphincter is weak or immature, what can happen is instead of it settling, it can backflow. It can come back up. So it is basically the concept of indigestion. A lot of times, when we're older, we're going to refer to it as heartburn because it's a sensation we feel. It feels like it's our heart that's burning, but it's really happening in the esophagus. This is typical in our patients that are infants because of that immaturity of that sphincter and how they're nourished. They're fed a lot of times laying down. Like, a mom will hold the baby kind of reclined while they're feeding them. And they may finish feeding them and then it's like, oh, I got to get things done. So then they're, packing the baby around and we've got all this movement jostling them. And then we might decide, okay, it's time for a nap. So now we're going to go lay them flat again when they've just had all of this, substance swallowed. So you're going to see a lot of that playing into how we manage it in just a second. The amount of regurgitation is typically referred to by, what would be a visual that's easy to compare it to, like dime-sized, quarter-size. Does it actually fill up a burp cloth? Like, that's important to know. It's typically recurring, so we'll see it, happen routinely, and sometimes it's an intolerance to what they're being fed. So it might be the formula that they're receiving is not broken down enough, and we need something else instead that's going to, be easier for them to digest. It could be that it's too thin. So you'll find that sometimes the recommendation from the pediatrician is to thicken it, like with the cereals that we talked about, the rice and oatmeal cereals, which is not, again, cereal like Fruit Loops and Cinnamon Toast. This is cereal like infant form, and it's added to the formula, and it's actually meant to thicken it so that it has more weight and can stay down once it's consumed. Kind of going back to chapter 8, we don't recommend adding cereal to bottle feedings. That's something that a pediatrician has to order, okay? And that's just because of what? Well, I can't hear your answers, but I'm hoping you're thinking choking, aspiration risk, okay? That we would rather them have that introduction of solid food with a spoon than being added to the bottle, because we run the risk of them choking and aspirating if they're having to swallow these thicker substances. So mid-sternal discomfort, throat pain would be other examples. That burning in the esophagus. Again, these are not things that the child's going to be able to verbalize. You're going to see evidence of it, and if it doesn't actually result in them truly throwing it up, then it might be that the patient is fussy for, up to an hour after they ate, and that's because during that time, they're not feeling relief. They're still experiencing this discomfort. They can develop a cough, and it could be associated with them actually choking on some of that reflux contents. They can have slow to no weight gain, because if you think about it, if everything they're eating is then coming back up, then it's obviously not making it to the portion of the digestive tract that actually allows the nutrients to be absorbed. So we would expect there to be a lack of weight gain or very slow weight gain, and the child will be uncomfortable. So they'll be irritable, they'll be crying, and they may even be arching their body, and that's their way of trying to get some relief. I reference a particular syndrome called Sandifer syndrome, and that is basically the sudden arching of the head, neck, and the upper trunk of the body due to a reflex that's, when they're compromised while feeding. So basically they'll start twisting their head from side to side continuously, and sometimes their trunk is actually bent to one side with the head facing the floor, because they're trying to keep from choking on what they're having a hard time swallowing and keeping down. So this is a natural reflex. When GERD occurs in older children, they'll typically describe an epigastric pain as well as that mid-sternal discomfort. It can affect their sleep, and they'll also typically complain of throat soreness that's persistent because of that burning sensation when it's coming back up. And then there's also the potential for silent GERD, where milk is entering the esophagus and creating this burning, coughing, and choking, but the baby still is having appropriate weight gain. They're still wanting to take their bottles, but this can still be a recurrence for them. And so obviously we want to address it if we observe any of that indication. So how do we address it? So really, one of the best ways is to reduce the volume they're consuming at any one time. Just like if you think about, a time where you went somewhere like a buffet, or maybe your mama's cooking and it's just so good and you ate past the point of being full, like you should have stopped at, this portion, but you kept going, and then all of a sudden now you're having this, belching tendency and this burning sensation, and you keep thinking it might actually be better if you just go to the bathroom at this point. Having that smaller volume of feeding is definitely one approach to help manage this well. And then, as mentioned earlier, it could also be the thickening of the feeding to help manage it so that it weighs more and stays down. Frequently burping the child, giving them breaks between ounces of formula and intentionally burping them. If you're not familiar, and that's okay if you're not, but babies and even our young toddlers don't always have the natural tendency to belch when they're experiencing that air excess in their body. So that's why a baby is burped, because we have to help them get that out. Because if it doesn't come naturally for them, then it stays in them and it's creating this, increased pressure because it hasn't been released. Having the child in an upright position, both when they're being fed and after they're eating, is ideal. Making sure that position doesn't create abdominal compression. So you'll see in textbooks and in our PowerPoint, avoiding a car seat. Even though you think of like a car seat as being something that positions the baby upright, it's also a harness that's creating some pressure on them, especially in the trunk region. So a better would be like being propped up on a boppy pillow, or being put in a swing where they have that ability to kind of be at an incline, but without the bend over compression element to it. If you can identify triggers, then obviously avoiding them. Like it might be that they need a different formula, or maybe that they're having an intolerance to the mom's breast milk, and maybe she needs to, try figuring out what in her diet might be creating this reaction in the babies. Meds may even be necessary, like proton pump inhibitors, PPIs, like Prevacid and Prilosec. Anything that has that Zol ending. Hang on, let me see if I can. This is where I struggle the most, is the pronunciation of pharmacology. Pantoprazole, am I saying that right? Y'all aren't able to tell me, but that Zol, Z-O-L-E ending, that is the signature for a PPI. Another example would be Reglan or metoclopramide, which is approved for babies, infancy, like very young, to help with this particular problem. Zantac is another example that is typically prescribed for babies for this. Now, Zantac itself, I think maybe was removed for the market, but the generic of it, I can't right now think of what that is. Okay, so with the medications, those need to be administered approximately a half hour before the baby's going to be fed for them to be the most effective. And so usually that's how they'll be prescribed. And then in some instances, it's severe enough that they may even need surgery. And the surgery or the surgical procedure that coincides with the severe reflux is called a Nissen fundoplication surgery. When you have your rotation at Pediatrist and you're looking at your patient's chart and you're seeing all of their past medical history, a lot of babies, especially if they've had a G-tube at some point or any kind of gastric related diagnosis, a lot of them have had a Nissen procedure at some point, and that's this effort to try to help with the esophagus sphincter to minimize this problem. Triggers, and this obviously is speaking more to our older child, because don't expect this to be the diet of a baby, okay? But some triggers that are commonly associated with GERD include caffeine, chocolate, foods that are spicy or fatty, and also acidic in nature. Carbonation tends to do this, and even high fiber foods would be other examples. So again, you may have to alter the diet to see some results from this. Okay. All right, on to our next condition that is vomit related. Okay, so this one, pyloric stenosis. I don't know that you will have this in med-surg too, because this is by definition a pediatric, really it's a newborn condition or complication that is associated with the pylorus muscles, this is in the digestive tract, becoming thick and enlarged or swollen such that food gets stuck. Okay, it basically is preventing food from reaching the small intestine. So a good way to think about it is, stenosis means narrowing, right? So basically the passageway is narrowed. It's narrowed because of this muscle enlargement, but it is inhibiting the food from passing to the small intestine. So when the patient's experiencing pyloric stenosis, this is a structural defect, okay, that's occurring in their body. The way it's going to manifest is projectile vomiting, because it basically is like there's nowhere for it to go. Okay, there's an illustration in your textbook you can look at, and you can pull up additional photos online, but basically, here's this pylorus muscle. It has this swollenness to it, and it's creating this barricade that won't let the food finish passing. So the only place for it to go is back up where it came from, okay? So in this situation, it's still vomiting like what we had with GERD, but it differs in that it is forceful projectile vomiting. For those of you who are movie buffs, think of Pitch Perfect, okay? The character in the show who throws up with all things that cause her anxiety or frustration. And the way that they illustrate that is this vomit flies across the room. That's what we're talking about, okay? This forceful projectile vomiting. And with that, the patient is what we would diagnose FTT, which means failure to thrive, which means that both from a stature, a weight, and a growth and development perspective, they're behind, they're delayed, okay? So this is going to be your less than 5%, on the growth curve, on the growth chart kind of child. These babies look sickly, okay? They are what I would consider the epitome of emaciated. They have these very thin extremities that are basically just skin on bone. They typically have a potentially distended abdomen, okay? But everything else on them, their neck, skin, and everything, is just so loose because there's no fat there. They haven't been able to gain any fat on their body. These babies are also going to constantly be hungry, constantly be crying. Even though they're potentially eating, they're not getting the satisfaction of that meal because it can't get where it needs to be digested and to provide that, hunger sensation relief. So they're going to look like they're starving, and they're going to behave like they're starving. They will obviously be dehydrated. Their electrolytes will be imbalanced, which we know is very dangerous for an infant. We do see this most often in males. It can happen in our female infants, but it does occur more often in our male infants. And a signature indication would be what they call the olive sign, and it's because it mimics an olive mass in the mid-epigastric region. So this would be you palpating the belly, like we talked about previously with our full palm, gentle flexion, and feeling this mass in their stomach, specifically in the mid-epigastric portion that resembles this olive shape. So what do they need? They need surgery. No question about it. Whenever they are recovering from surgery, you can still experience some vomiting post-op, but usually that's because of the swelling nature, and so it does reduce with continued healing. Another thing that really needs to be emphasized is that these babies need to be burped very often, and it says after every feeding, but even potentially throughout the feedings, because that's going to help to decrease the amount of air in their stomach and prevent them from continuing to experience this. So we said infants, but really it's most often detected in the first week of life up till about 5 months old. So, really our newborn period through the first few months. Other things that you might be able to visualize with this are what they call peristaltic waves. These waves would be the peristalsis, that movement that helps to try to digest food, could actually be visible before they start vomiting. Like, it's what you would imagine a growling, angry stomach to sound and look like. The poor weight gain, the failure to thrive diagnosis, they're at risk for metabolic alkalosis and also jaundice. And I think that concludes the notes on that particular slide. So very much a pediatric specific condition, and very easy to distinguish from others in that its characteristic is the forceful projectile vomiting with the failure to thrive appearance of the baby who is constantly hungry, constantly crying, and may have a mass to go with it. Okay. So this is it says intestinal obstruction continued, because this is another condition in which obstruction is kind of the problem. But earlier it was due to this thickening and edema of the pylorus muscle. Now we're talking about a different issue. So intestinal obstruction is any mechanical or functional blockage of the intestines that prevents the normal movement of digestion. So it could be the small or the large intestine that's affected. In this situation, the intestine is really what they would consider telescoping into itself. I wish I had this object that I'm thinking of as like a visual demonstration, but if you've ever been somewhere and they've given you like a telescope pretend, and you pull it out to be able to see that greater distance, but when you're done with it, you collapse it, and all the pieces, go into each other to create a much shorter object when you're not using it. That's the telescoping we're talking about. So in this situation, the intestine is like telescoping inside of itself. And you can see some imagery of this in your textbook that accompanies. I just don't like the slides to be that busy, so I don't add them to the PowerPoint. So with this, the food and fluids they're consuming, they cannot pass through. Circulation is compromised because of this. It is a surgical emergency. They need to have surgery for this. And the ways in which it's manifesting is pain, but it may not be constant. It's actually more often, intermittent, which means it comes and it goes in regular intervals associated with them feeding. Okay, so that's when they're going to experience that pain, because they're eating and then the food's being blocked. It's unsuccessfully getting where it needs to go. The patient will have vomiting that is bilious, which means like bile. So we would expect green and bright yellow coloration to the vomit. Abdominal pain, and their stools will be different. It's described as a currant jelly stool. Well, in case you may not know, because I actually didn't know this before, coming back to pediatrics and teaching this content, but a currant, C-U-R-R-A-N-T, is actually a dried fruit, much like a grape. It looks a lot like a raisin. And so that is a color and an appearance of this fruit. And the stools that they're experiencing are this color that are bloody and mucus-like. So this dark coloration, bloody mucus, jelly-like stool. Definitely nasty. The patient will experience abdominal distension, especially with increased infection symptoms. It's going to make that worse. And it mentions a barium enema followed by surgery. So one thing you'll see, and this is a great, if this is all foreign to you, going to your book and kind of reading this section, this is the case with any of the conditions, but especially the ones that you maybe aren't as familiar with. Like, you know what appendicitis is, but you maybe have never heard of intussusception. Go read the book about it and kind of get that understanding, and then take away what's important and most significant to know from the PowerPoint slides in the lecture. So with intussusception, before surgery, they will attempt what's called a barium enema to try to remove the telescoped intestine. So basically, it's a last-ditch effort to see if we can provide relief for this patient. And sometimes it is effective, but generally it is not lasting. So even if doing this barium enema actually does return the intestine to its normal position, it's no longer telescoped inside of more of the intestine, it typically won't last, and surgery is still going to be needed. But it is an effort to provide some relief in the meantime, and that might be in the meantime, like until the baby's weighing a little bit more or is more stable and is expected to have a better outcome with surgery than just jumping right into that procedure. Okay, we're getting there. We're more than halfway. Our next condition is also in the obstruction column, and that is called necrotizing enterocolitis, and you'll usually hear it abbreviated NEC, and it's the letters NEC, NEC. But basically, take the medical terminology you've learned prior to now to help you better understand what these conditions are, because NEC is probably not one you're going to hear about in adult health. So NEC, or necrotizing enterocolitis, is tissue death in the intestines, and that makes sense because necrosis literally means tissue death. Okay, so necrotizing enterocolitis, tissue death in the intestines that is often seen in premature and chronically ill infants. Excuse me. Many times these babies have other problems besides NEC. They were born very, very early, and they also have probably had some form of infection or some kind of ischemic incident. So there might have been some strangulation of a portion of the organs, or they may have had an infection in utero that is contributing to this problem for this patient. And it says usually follows illness and infection. These babies are going to present with a distended abdomen that's going to be hard when you palpate it, and they will maintain a large gastric residual. What is a gastric residual? Well, if you think about a patient with a PEG tube, okay, we have a tube placed in their gastric cavity that's being used for food administration. When you check a residual on them, you're going to that tube port and you're attaching usually a 60 cc syringe that's currently closed, and you're pulling back to see how much residual or remains are left in the abdomen from the last time the baby was fed. Okay, and that has to be considered because the stomach capacity is only so big. So if we've already got, an ounce in there, well, we may not have room for any more feeding to happen until that has been digested. Okay, and then there's the question of why isn't it digested? What's going on with the digestive process that's preventing that digestion from occurring? So this is saying that with these babies, and again, this is our newborns we're talking about here, usually very, very early on, that from feeding to feeding, they're going to have a lot that remains because the intestines can't absorb and digest like they're supposed to because of the tissue death or necrosis that has occurred. Remember we talked about, a term infant's stomach capacity is 30 mils, which is 1 ounce. Okay, I mean that is so small. I don't have a measuring cup or a medicine cup with me, but I mean very minimal. So when they say large gastric residual, in your notes it says, or in my notes it says greater than 2 mils. You're probably thinking 2 mils, that's large, like that's nothing. But it's not nothing when all they can actually allow is 30 mils to begin with. Then it's definitely significant. So these babies would be NPO, nothing by mouth, and that is to give time for the GI tract to heal. They also typically need surgery because they have to remove the portion of the intestines that the death has occurred and it can't be reversed. Okay, so there needs to be a resection of some of that intestines, and usually what these babies are diagnosed with after the fact is what they call short bowel syndrome, because now they don't have as much bowel as they should have or did before because we had to remove some of that due to the tissue death. These babies may need or will need a NG tube and possible colostomy when they have that surgical resection, but it's not always permanent. So, in many instances, it can be reversed once the body has healed. It doesn't mean that they're going to be dependent on that long term. Other manifestations it mentions is blood in the stool. The baby can experience periods of apnea where they're having, absence of breathing, decreased blood pressure. Let's see, the temperature, their body temp is hard to maintain, so they're having some thermoregulation issues. These babies would receive IV therapy, but not anything orally to eat, allowing the GI tract to rest and heal. And then, ultimately TPN is the parenteral nutrition and antibiotic therapy for these babies, because it's usually, again, following some kind of illness or infection. And then we mentioned already the NG tube and colostomy. All right. Once the surgeries are performed and the symptoms have subsided, these babies will be gradually introduced to oral feeding. It's not going to be, just a quick change in their routine. Some of them do still require long-term parenteral nutrition because, we have to still give the body time to heal and to learn how to then be responsible for the digestion of nutrients. But our goals would be to eventually get them to where they're having enteral feedings again, so PO feedings. Whatever they're at as far as their developmental phase, that's the kinds of foods that they're going to be introduced to. So, it depends, obviously, if they're still babies and this is happening, then they're getting, formula, breast milk. They'll start solids when a baby normally would, between 4 and 6 months. They'll get to have the same introduction as what we would expect with the baby that didn't have this past medical history. Okay. All right. Next one, gastroenteritis. Definitely we'll see this in MedSurg 2. This is what we most often refer to as a stomach bug. So there is some kind of infection in the gastric area due to this invasion. And with it, the typical presentation would be nausea, vomiting, diarrhea, and abdominal cramping. Basically, you may or may not have fever and chills, though that is very likely. Whether you're having that might be related to whether it's a bacterial versus viral infection, but many times gastroenteritis is going to be viral, meaning it has to run its course. Of course, if it is bacterial in nature, that's great because then you can usually be given an antibiotic and that will help that to subside more quickly. I have a note in here to tell you to look at page 381's clinical judgment because it speaks to both the patho and signs of dehydration. So that's where it's at in this portion of the chapter, and that is important to know for other purposes than just this condition, but while we're talking about this condition. Let's see. Our greatest concern is obviously dehydration, which we've already covered. I do include here that the patient who's experiencing gastroenteritis should have feeds withheld for a few hours because we want to give their stomach, their gut, some time to rest. If we're trying to reintroduce feedings too quickly, we're just going to keep having the same response by the body. You might note in the textbook that it is not encouraged that a child receive antidiarrheals or antiemetics. So medication to stop the diarrhea and stop the vomiting is actually discouraged. And if you're unsure why, think about it. If we have this pathogen invasion, right? We've got this virus or bacteria that's created this infection, and we don't allow the body to poop and to vomit, then we are holding on to that bacteria or virus in the stomach. It is going to continue to be there and fester if we can't get it out. So even though the logic would be, oh, well, if their symptoms are throwing up and having diarrhea, then we should give them something to stop those things. Yes, in some situations it is severe enough to need it. And obviously that would be when the risk is outweighing the benefit, when we're having the degree of dehydration concerns that they might, be unstable as far as risk of fatality. But in many cases, they can be managed while they're still undergoing those symptoms of diarrhea and vomiting, which is helping to rid the body of the infection. Once the baby is able, or the child, I won't say baby because this is not just for infants, once the person can have fluids resumed or reintroduced, it should be a gradual process. And this is where that oral rehydration solution or oral rehydration protocol kind of comes into play. So you'll see mentioning, and this will differ depending on your resource. In fact, I think ATI says something slightly different than your textbook. But in either case, because it's the supplements or the resources we're using in our course, if either of these answers were what you provided, it would be acceptable. But some things say a teaspoon every 15 minutes for an hour, which would be 5 mils. Others say a tablespoon, which is 15 mils every 15 minutes for an hour. We want to see them be able to tolerate that smaller volume for an extended time before we start increasing. And then from there, we will gradually increase and continue as the patient tolerates it. If vomiting were to recur, if it was to happen again, we stop and we start over. Okay, so if, let's say we had gotten up to, 30 mils or an ounce every 15 minutes, and they had been tolerating, up to this point, but now they're throwing up again. When we do reintroduce it again in a few hours, we're starting back over at that 5 or 15 mil amount. They probably won't resume a regular diet for a day or two, depending. But as soon as they can, of course, we want that because that's the healthiest thing for them. You'll see mention, especially in your ATI book, of the BRAT diet, which is standing for these soft and bland foods like bananas, rice, applesauce, and toast. It also includes crackers and potatoes. But these are foods that can be substituted because they're gentler on the stomach and they can be tolerated well until the patient has had a little bit more time for the gut to rest and heal. What we don't want to do is just resort to like chicken broth and, even Gatorade the whole time, because though there are some benefits to these things, chicken broth has very, very high sodium concentration in it, and we can have, a different consequence with our electrolytes than what we were going for. And depending on, what amount of these electrolyte solution drinks they're getting, we don't want to send them into the opposite problem of where they're now having an excess of some of these electrolytes where they were having a depletion. Okay. So anytime you hear ORF, oral rehydration fluid, okay, yeah, I think that's right. Sorry, I was thinking there was another abbreviation for it. It is ORS, oral rehydration solution. Okay, that's how it's referred to in medicine. That is talking about the medical equivalent of like a Pedialyte, or the medical equivalent of like a Gatorade solution, where it's a certain percentage of the electrolytes in this liquid. Higher concentration, so that smaller volumes provide that, but it's being, basically it's a medicated version of what we would say when we say Pedialyte or Gatorade. Okay, constipation. So now we're switching gears. We've left the topic or the section of conditions that was manifested by vomiting in many instances, and now we're talking about constipation. And I think this might be the only, maybe two conditions in this category. But one of them was what they referred to as functional constipation, which basically is the constipation you and I know when we suddenly have, less frequent bowel movements, or the bowel movements we're having are harder than normal, not as easy to pass. Oftentimes they hurt. They could be very large, like we've kind of been impacted and now all of a sudden it's coming out, or it can even be situations where it's a very small amount. And usually that's due to like some hydration concerns, or even maybe some kind of blockage, which we'll talk about in a second. But functional constipation is essentially the bowel movements becoming less frequent, harder in nature, and more difficult to pass. Ways to address it would be increasing fiber fluids and exercise, because we know all of those things are going to, on their own prevent, but in this case help reduce this constipation tendency. And then there may even be need for some medications that's also going to gear towards relieving that constipation. In some instances, especially in pediatrics, it can be more of a psychological thing. It can be a behavior, a choice to not go to the bathroom. We see it a lot in kids in settings other than their home, where they will literally hold their stool all day long because they don't want to go at school, or at a restaurant or something like that. It can be that they've had some kind of experience where now they're scared to use the bathroom, and so they're withholding that stool for that reason. An example might be they had a time where their stool was very hard, difficult to pass. It hurt a lot to do so, might have even resulted in some bleeding, and now they're afraid to poop because that was such a miserable experience. And like I've seen that with like my nieces and nephews have done that before. And so sometimes, you'll see the approach to, or the management focused on behavior modification with something like a reward chart, where we're giving them stickers or candy or something when they go to the bathroom, because that is the only way to try to, retrain them to not hold in their stool, but to actually go and use the bathroom. So deciding or finding out kind of where the issue is for this particular child is important, because we need to know, is it diet, nutrition related? Is it exercise and immobility related? Or is it something more psychological where it's a behavior, decision? Okay, Hirschsprung's disease, another condition that is signature is constipation. And this one, I definitely want to I don't have any additional notes than what you see on the screen, but I definitely want to explain it to you because it's one of those that's kind of confusing, and you're probably not going to hear about it in any other course because it is a pediatric condition. So Hirschsprung's disease is something congenital. They're born with it, and it's associated with the nerve function lacking in the colon. So from birth, they have this lack of nerve function in the colon, and the consequence is intestinal blockage. So we're having problems with the digestion. Basically, the peristalsis portion of the digestion is impaired. This is primarily males, and that's because of its genetic nature, but it's generally males that experience it, and it's evidenced from day one because these babies can't pass meconium. So it's figured out very, very soon after birth that they have this nerve function problem. When they do eventually pass stools, so it's not necessarily a situation where like it's never going to come out, okay? It's not normal, the elimination of meconium. So when they do have bowel movements, because of this nerve function and blockage, the stools that they have are very minimal, and they don't have the typical appearance. They're what they call ribbon-like stools. It would be good to imagine like if this were the, say, rectum, and we had this blockage in it, then this is the stool that's able to seep around the blockage, okay? It's very small in nature, usually both volume and its like shape and size, because it's whatever can get around what's blocking that exit, if you will. And so here's the kind of like trick or irony with it. Sometimes these mamas will say that their baby has diarrhea because with every diaper they have, there's some stool in it, and it's more watery or ribbon-like in appearance. But it's actually not diarrhea. It's actually constipation because it's this little amount that's being able to be eliminated, and there's still all this other stool that's being retained, if that makes sense. So even though we may see it with every diaper, and it may seem thinner and looser than normal, it's still technically, by definition, constipation. These babies will typically exhibit vomiting. They'll have an abdomen that is distended. So these babies have an appearance in which they have the protuberant or distended abdomen, but thin extremities. And if you remember previously, we talked about, you know, when a baby was like that, the possibility was pyloric stenosis. They had a rounder stomach, but everything else on them was very thin and no fat to it. So this is another condition that can have this presentation. They typically are diagnosed failure to thrive because they're not getting the nutrients from their feedings. And this is one where we'll also see an enema as an effort to provide some relief, but it's not going to be a fix. It still will require surgery. So it's more just like a Band-Aid till we get to the surgery. And sometimes with Hirschsprung's disease, they may have multiple surgeries, or what we call a surgical series, to complete the repairs that, are needed for this. Okay. Gastrointestinal disease associated with the esophagus. So now we're talking about some structural diseases. I did include cleft lip and palate on this page, but at this point it's not being part of what we're introducing because it's already been taught to you. We had this with chapter 8. It can still be actually, no, I have a little note I'm reading as I'm talking to you. It will not be on this unit exam because it was tested when we covered it previously. So just remember that this is one of those conditions that does impact the GI function because it is something that can interfere with their eating, but it's one that we've already addressed. Okay, so esophageal atresia. Esophageal atresia, we know that in a normal anatomy, the esophagus connects the mouth and the stomach. When a patient has diagnosed esophageal atresia, there is a defect causing an interruption in that connection. So basically, the esophagus ends in like essentially a blind pouch, okay? It doesn't connect all the way. So we have a gap. Think of like a railroad track that's trying to get you from point A to point B, but somewhere between point A and point B, the track is broken and the train cannot get where it's supposed to go. So with this, the patient is going to have feeding difficulties immediately. This is another congenital condition, so this is present from birth for this baby. It may not have been visual in ultrasounds, but it already was present when the baby was being developed. The manifestations include bubbly, frothy secretions, difficulty breathing, especially when they try to eat, and consequentially cyanosis. So even though we've talked about like what acrocyanosis is, that normal discoloration in the first 48 hours of life, you know, this would be above and beyond, okay, that needs to have surgery. Whew, sorry, y'all. This baby will require surgery, you know, very soon after delivery, and they will also, in the meantime, require frequent suctioning. This is not just suctioning like the bulb syringe and saline in the nose that we talked about in our Unit 1 content. This is suctioning that might still be using a bulb syringe, but even could result in the need for the Yonker or the DeLee catheter. We're getting all of those secretions from the mouth primarily in this situation. Make a little note on here that says any condition GI related that requires surgery will have similar nursing care management. The pre-op care, which typically is MPO, maintaining hydration and adequate oxygenation and trying to prevent the chances of aspiration and choking. And then from post-op care standpoint, the education, the recognition of what are signs of infections, the gradual progression of diet once the child's ready for it, and that requires active bowel sounds for one, and that they're also still receiving non-nutritive sucking you know, experiences like with a pacifier to satisfy that normal development. Okay, these particular conditions that we're going to speak to, this is literally all you have to know about them, what you see on this slide. Okay, very, very brief. They are genetic or congenital as well, and they are associated with some defect to the abdominal wall. The difference in these two is essentially one thing. Okay, but both of these are emergencies that require surgical intervention that is usually performed in a series of surgeries, or what they call surgical stages. Okay, so an omphalocele is when the stomachs and intestines are outside of the abdomen, but they are contained in a sac. So basically, there's these abdominal contents that did not form within the abdomen. They actually are sticking out of the stomach, but they're contained in a sac. Gastrochysis, same thing, stomach and intestines outside the abdomen, but there's no sac containing them. Okay, both are dangerous, both require surgery and are considered emergencies, but the difference in them is the presence of the sac versus the absence of the sac. Our main nursing management and goals for them is to prevent fluid loss, help them with maintaining body temperature, and reducing likelihood of infection. So we're not going to get into what is done for them because this is a specialized problem, but basically, you know, all of the efforts that are being done, the intention is prevent fluid loss, maintain body temp, and reduce chances of infection. Okay, this slide is kind of like our miscellaneous, so it's problems associated with other organs in the digestive tract, specifically liver, pancreas, and gallbladder. Several of the ones that your book covers that are not listed here are going to be covered in MedSurg 2, and because there's really very little differentiation in the pediatric and the adult form, we're not testing and teaching that here. And so that would be cholecystitis, gallstones, and Hep A. You're going to be taught and tested on all of those in MedSurg 2. We've already covered neonatal jaundice. We had that in chapter 8, or even maybe 7, when we talked about the patient with the high bilirubin and needing the biliolite. So we've already taught it and tested on it. And then cystic fibrosis, we had that, or depending on what order you're getting this in, it is being covered in the respiratory chapter, which is the other chapter on this exam. So the only thing that really needs to be touched on here is what pertains to the gastric function, or the GI side of CF. And I honestly don't know if I left it in here. Yeah, I did. Okay, so here is that information that I copied over from the chapter 12, respiratory content, where CF was brought up, and we're going to just focus on the GI element of it. So remember, CF is an overproduction of mucus. They have an underproduction of pancreatic enzymes. This is a condition that's very serious in kids. It can be the cause of childhood death, and we do see it as a more common condition that presents. Children with CF are experiencing malnutrition due to blockage of enzymes responsible for the digestion and absorption of nutrients. So they're malnourished because the enzymes that they need for digestion and absorption aren't functioning properly, or they're not being produced adequately, and they're not functioning properly. So they basically need supplemental pancreatic enzymes, and that's one of the management measures for this condition, is that they're going to be on lifelong pancreatic enzyme supplementation. This condition can affect organs throughout the body, causing great damage and disease, which could result in childhood death. These children do tend to stay sick. They experience chronic infections because of their immunocompromised state. They have a similar presentation physically, as we've seen already with several other conditions, where they have the thin extremities but the protruding abdomen. They also can manifest with digital clubbing that's associated with hypoxia, or decreased oxygenation of the tissues, different adventitious or abnormal breath sounds like crackles and wheezing because of fluid accumulation and inflammation of the airway, salty taste to skin, steatorrhea, and then in some instances these children go on to be sterile later in life. I did put a little note on here just reminding you that steatorrhea is fatty, bulky stools that float in water or in the toilet. I made mention that children with CF have higher drug clearance, which means that they typically need higher doses of medications to get the same impact that normal or children without CF would normally have required. We recommend avoiding antihistamines in patients with CF because the drying effect which does help to reduce mucus production, can make elimination of mucus more difficult. So if it gets too dry, just like how we talked about the babies in the beginning of the course needing the saline to thin and loosen those secretions so they can be expelled, if they experienced too much dryness of mucus secretions, then they won't be able to be eliminated. Pancreatic enzymes are effective for approximately 45 minutes to an hour after they're administered. So the recommendation for pancreatic enzyme supplementation is that they be administered with the start of a meal or snack. So like previously in this chapter and in this lecture, we talked about GERD and how we want them to receive that PPI about 30 minutes before they eat so that its onset has occurred when they're ingesting food. With the pancreatic enzymes, because their duration is 45 minutes to an hour, we want them to have it as they start the meal, so or snack that they're going to be given. And this is to promote digestion and absorption. And so, you'll have CF questions on this exam that pertain to the GI system, but also to the respiratory system. And so we talked about the respiratory symptoms previously, that, a patient can experience both respiratory and GI or the combination. That the GI symptoms, we talked about the steatorrhea, the oily fatty stools that float, also rectal prolapse, failure to thrive or that poor growth in nutrition, the chronic diarrhea, and then the need for the supplementation, both pancreatic enzyme and vitamins with meals and snacks. It does have a little note in here that your book talks about mixing with soft acidic foods, not dairy products. So when they're given these enzymes at the start of a meal or snack, we're avoiding dairy products because they interfere with their function or their absorption. Let's see what else. Cystic fibrosis, hereditary disorder affecting the exocrine glands, thick mucus leading to blockage of ducts, intestines, and bronchi. First manifestation is often a meconium ileus. It can result later in life in pancreatitis and diabetes. I think that's it. Okay, and this is, yes, the last slide for this chapter. So this last one is referencing nutritional changes, or that's what, the GI problem manifests as, and we're not testing on obesity. You will have that with adult health and MedSearch 2 if you haven't already. And failure to thrive, we've already covered. So it is something that you might see on this exam. It is likely not going to be the focus of the question, but definitely an element to the question. So if you haven't previously looked at it, I would review that information. Remember that was presented in Unit 1, and then it should have also been in the chapter in Chapter 16 as well. And that concludes our GI lecture, Chapter 16. So I hope that you learned a lot, and if you have any questions, you can send those to the faculty via email. Thanks.